Hello, and welcome to today's Lunch and Learn presentation, What's New with Spinal Surgery? I'm Dr. Steve Reinches, the President and CEO of North Kansas City Hospital and Meritas Health. Thank you for joining us. Your spine is made up of a series of bones that stretch from your head to your tailbone, and it protects your spinal cord. It allows you to move and stand and bend. If any of these bones are damaged, or if the spine structure changes, it can restrict your movement and cause pain. Depending on the injury, surgery may be the best treatment option. We are fortunate to have some of the best neurosurgeons in the city on our staff, and I'm excited to have you meet one of them today. Dr. Ammar Hawasli is a board-certified neurosurgeon with Meritas Health Neurosurgery. He will talk about some of the latest spine procedures and their specific benefits. Dr. Hawasli went to medical school at the University of Texas Southwestern Medical School, and he completed his residency at Washington University. In addition, he completed a fellowship in spine surgery in St. Louis at WashU. Please join me in welcoming Dr. Hawasli.
Hello, thank you for having me. I do appreciate the invitation and the chance to speak to the community. My name is Ammar Hawasli. I'm again one of the neurosurgeons here at Meritas Health and North Kansas City Hospital. And today I'm going to introduce you a few new concepts and ideas about what's new with spinal surgery and the treatment of spinal disorders. Spinal disorders are a very common problem. Back pain is one of the most common problems people present to the primary care doctor for. It's probably the third most common by many people's accounts. It's a major problem in society, leading to significant pain and health problems throughout the country and throughout the world. And today we're going to kind of briefly review what's new with spine surgery and what's new with spinal treatments in general. The goals of this talk today are to describe the basic ideas and principles in the diagnosis and treatment of your spinal condition, and then to introduce 4 modern innovations in spine surgery that have really improved outcomes and improved patient care over the last several years. I do not have any disclosures today. So what goes in the modern treatments of spine surgery? It's not just one thing. There are many items that go into treatment of spine surgery. There are many pieces to the puzzle to treat spinal disorders. It basically involves 4 general concepts. The first is a patient-centric approach. This is generally a concept that means we really focus on what the patient's problem is, what your problem is. We try to figure out what your concern is, what's bothering you, and what's impairing your life. And we focus on that to treat you. The second general approach is a team approach. Medicine, and especially spine surgery, is not a one-stop shop. It's not a place where one doctor or one nurse can treat your condition. It requires a team approach. And as we'll talk about here today, in the modern era, and especially here at North Kansas City Hospital, we're able to provide a team approach in one setting, in one environment, in one system to be able to address your problem comprehensively. The third concept is evidence-based medicine. It's keeping up with the up-to-date medicine, the up-to-date data and information to provide the best treatments, and that will improve your outcome overall. And finally, in the part we'll focus on a little more on today, is providing up-to-date interventions and keeping up with the modern treatments available in spine surgery. So the first general concept in spine surgery is patient-centric medical care. Some people describe this in other fields as precision medicine. The general concept is we really tailor the treatment to the individual patient. We really listen to the patient in the office and we hear what they have to say and hear what's bothering them very carefully. And then we try to examine them and look at their imaging and other studies and really focus the treatment on the patient. It addresses the patient's main problems and addresses their goals. It really treats you as the patient. The goal is to treat you not just your imaging, not just your MRI. It's to treat you. The next idea, an important part about this patient-centric medical care, is really a good office assessment. Having a good and set up time to sit down and chat about your problem, examine you, and review your imaging with you is critical in patient-centric medical care. It allows us to be able to really focus in and hone in on your problem. Patient-reported complaints are very important as well. So these can come in the forms of handouts or pain diagrams. On the slide here, you can see an image of a pain diagram that a patient has drawn where they focus in on where their pain is. It hurt this in the top image here. This person has back pain that goes down the legs, in the front and the back. On the bottom image here, a different patient has pain in their spine that goes to their arms. This helps us guide the treatment to improve their outcome and really hone in on where the problem is in the spine. Finally, questionnaires can be very helpful. There are many validated questionnaires in medicine and in spine surgery. This not only helps us predict outcomes and guide treatment, but also helps us follow you a long term to see how different treatments are helping you. Between these four ideas, we're able to provide patient-centric medical care. The next general idea is a team approach. So that all starts with you. You are the goal. Your primary care doctor is the quarterback. They able to diagnose you and really manage your care overall and lead you in the right direction. Then many other team members and clinicians are involved. A spine surgeon is involved, a pain management physician is involved, neurologists and physical therapists are involved, radiologists, there's non-traditional medicine and bariatric wellness as well. There are many other team members involved in this. And in order to take the best care of you, we have to take a team approach. Fortunately, in this institution and here, we have all these tools available for us, and we can function as a big team and essentially a large center to be able to take care of you in a very comprehensive way, and we communicate well with one another. This is a very important part of modern spine surgery. In this slide here, I don't want you to look at the details of it, but this is basically a doctor's way of thinking about how to diagnose and treat low back pain that goes down to the legs. And the purpose of this whole figure is to point out one idea. It's that many people are involved. It's not just one person that can diagnose and treat this problem. It's many people. It involves a team in order to successfully treat a patient like you. The third general idea is evidence-based treatments. In the modern pandemic, you've heard lots about evidence-based medicine and clinical trials, and spine surgery is no different. There have been numerous trials and studies to help us diagnose and treat medical problems in spine surgery and guide our treatments to figure out which treatments are best for which patient. And it is the neurosurgeon's job or the spine surgeon's job to really parse through this data and information to try to pick the best treatment for you. But it is imperative that the treatment be evidence-based and modern, and that provides the best treatment for you. The final idea in this paradigm here is up-to-date interventions. I'll review a few simple ones here and then go through some more in detail. So for example, physical therapy programs need to be up to date. They need to move on. And many physical therapists can provide excellent physical therapy. Here, for example, we have a program called the Move Plus program that is an up-to-date advanced physical therapy program that keeps up to date with the interventions, and so it improves people's outcome. That's what it's all about, the patient's outcome. Pain management treatments also have advanced treatments that are always changing, whether they're epidural injections or ablations, or procedures such as the mild procedure or spinal cord stimulation and more. There are many advanced treatments that are up to date. In spine surgery specifically, we have a program called Enhanced Recovery After Surgery programs. These are piggybacked off of other procedures that have performed in surgery. And the concept of this is to improve patients' outcome by enhancing their recovery. And finally, we'll go over several modern innovations in spine surgery. I'd like to briefly mention enhanced recovery after spine surgery. In traditional care, it takes patients days to weeks to recover from spine surgery. This is basically when they come in, they have surgery, and they leave and they're given pain medications. With enhanced recovery after surgery, this is a modern approach to treating a problem where we really focus in on the things that really speed people's recovery up, such as prehabilitation, rehab, special nutrition, special medications, and certain features about surgery itself. And by doing these things, we can really speed up their recovery so people can return to play and return to work and recover faster. here at North Kansas City Hospital, we found that this has reduced hospital stay by 20%. In other studies, including some that I've done in the past, it reduces opioid use and recovery time in general. So up-to-date interventions and changes like this really do help patient outcomes. And it's important to consider this and something you can be offered. So I'm going to go over some of the innovations in spine surgery. And there are many to be discovered and many to be talked about. But what I'm going to talk about here are not fads. They're things that have lasted a long time. I'm going to talk about durable innovations, ones that have lasted and have proven to be long-lasting and real. And these have revolved around 4 general themes. First is motion-preserving surgery, different types of spine surgery that allows people to keep moving, i.e. not fuse the spine. The second general concept is minimally invasive surgery. Minimally invasive surgery basically involves accomplishing a complicated task through smaller approaches. Many people think of it like trying to build a ship through a bottle, and these tend to improve patient outcomes in many people. The third general innovation has been image-guided surgery, and I'll go through that in detail. Essentially, it's basically using a navigation system or essentially a GPS for the body to be able to successfully and safely accomplish surgical goals. And finally, there's a general idea and understanding that we need to maintain or restore the alignment of the spine to improve outcomes. I will go through each of these in some detail now. So the first durable innovation has been motion-preserving surgery. So one example is disc replacement technologies, and other motion-preserving technologies and treatments have really helped patients with debilitating spinal conditions while maintaining normal motion of the spine. In the past, when someone had abnormalities in their spine and some level of instability or problem with their spine, it always required a spinal fusion. But modern motion-preserving surgeries are alternatives to this. They're alternatives to spinal fusion. They accomplish the goal and improve outcomes without artificially fusing bones together that are supposed to be moving in the first place. The first and most successful example of this is the cervical arthroplasty. This is a disc replacement. There's no need for a fusion. It's indicated in some, but definitely not all patients. If somebody has very severe arthritis, this tends not to work as well. But if a young person comes to clinic with terrible arm pain and a disc herniation, this is often a great approach and leads to excellent outcomes and a theoretical and likely, for sure, less future in the surgery because you're not artificially fusing joints together. On the image on the right, you can see an X-ray of an example of an artificial disc that was placed. The disc was removed, the bone spurs and the disc herniations that were pushing on the nerves were removed, and then the disc was replaced with an artificial joint at these 2 levels, which can keep moving. The person can still move their neck completely normally. This X-ray is taken with this type of implant called an Mobi-C implant, one of the original ones studied in randomized control trials. The disc replacement here is called M6. It's a different type of disc replacement, a 3rd generation disc replacement. And these all require the right patient selection, but these have excellent outcomes and no need for a fusion. Older surgeries that have been used in the distant past have become much more common now because the idea is to avoid fusions. So a laminoplasty procedure is a technique where someone can treat spinal stenosis and essentially reconstruct the spine, but avoid some of the problems and issues involved in either just removing bone or fusing bones together. And so other techniques with technological changes such as plates like these have allowed for a motion-preserving surgery. It's not just limited to the neck, fortunately. There are motion-preserving surgery options in the low back. In addition, so often spinal fusions aren't even needed in the first place, and we can just remove a small window of bone or treat discs. But occasionally, and those are those avoid spinal fusions, and we do them very, very commonly. But occasionally, patients need some level of stabilization, but we want to avoid a fusion. So there are 2 types of examples I have here on this slide describing 2 types of fusion alternatives. This is a special device placed in the spine after you accomplish your decompression, i.e. removing bone or ligament pushing on the nerves. And this essentially serves as a stabilizer to the spine. This is undergoing final phases of approval from the FDA and should be approved imminently. But this is an example of a treatment of spinal problems where you can avoid a fusion, but still address some of the instability. In Europe, they developed the posterior facet replacement or joint replacements, and this also is imminently will be approved in the United States. These are two examples of fusion alternatives in the low back, which can address some level of instability, but not have to fuse the bones together. So in summary, motion preserving surgery is a modern innovation that is really good and will be moving forward a lot in the next decade. The next general concept in spine surgery is minimally invasive surgery. Minimally invasive spine surgery improves patient outcomes by reducing the length of the hospital stays, the time off work, and the opioid usage. The basic idea is minimally invasive surgery leverages or uses modern technologies to essentially reconstruct the spine and indirectly take the pressure off the nerves. By doing this, you can essentially, like I said before, build a ship through a bottle. This leads to improved patient outcomes. Here are some examples of minimally invasive surgery. So in this x-ray, you can see up here on the top left, you can see that one vertebra is slipped backwards relative to another vertebra. This is technically called a spondylolisthesis. This patient is suffering from neurological symptoms associated with this. Using minimally invasive techniques and technologies, we can then attempt to treat this, but not do a very large surgery. So in this patient, you can make a very small incision, and through a small incision, accomplish a goal of taking the pressure off the nerves and reconstructing the spine, thereby treating their neurological problems, but also getting them back to work faster. Here's another example of a person who had a similar problem where you make a small incisions in the back and you're able to accomplish a lot of surgery through small approaches. There's a different approach, a different type, where normally if you wanted to do a spinal fusion, you'd have to make a very big incision to get to somebody's spine. Using this particular technique, you can make smaller incisions and avoid a large surgery. I can provide other examples. For example, here, there's a person who had a slipped vertebra leading to spinal stenosis. And when the person laid down and their vertebra slipped backwards, they felt fine. But when they stood up and the vertebra slipped forward, they had severe spinal stenosis. So by making very small incisions, one on the side and two tiny incisions in the back, we're able to place these implants and stabilize the spine, and the person can leave the hospital the next day and go back to work within a few weeks, avoiding a large surgery once again. Here's an example on the right of an even larger situation where somebody presented with a deformity of the spine after years after a previous surgery, and making smaller incisions, you're able to reconstruct the spine around using smaller incisions. And again, they can recover faster and return back to their normal lives faster. So minimally invasive spine surgery has its advantages. It's not appropriate for everybody, but it can help some people. And it is one of the main innovations and drivers in spine surgery currently. It's important to note that technologies drive minimally invasive spine surgery. So different technologies can improve your approach. So in this situation, a person had a deformity of the spine where they had a fusion below their spine and they were essentially unable to stand up straight. But by using specific types of technologies, you're able to address deformities through small approaches. We do know that minimally invasive surgery improves outcomes. There are many, many randomized trials and unrandomized trials showing this. Here's an example of showing that when you have traditional surgery, people spend many days and several days in the hospital, depending on how many levels are involved. But with minimally invasive surgery, people usually spend 1 day in the hospital, maybe 2. They leave very quickly. They don't need as many opioids, and they tend to go back to work faster. The amount of disability goes down significantly after minimally invasive surgery. The next general concept in this field is image-guided surgery. This has revolutionized both brain surgery, but also spine surgery. Stereotactic guidance systems, or essentially what you think about as a GPS for your car, but for medicine, includes navigation system and spinal robotics. And these have really increased the accuracy and safety of spinal fusions. On the left here is an image of one of my partners, Dr. Reichs Jr., performing image-guided spine surgery, where he's placing implants in the spine using an image-guided system where he knows he is placing a screw exactly where he wants to, within millimeters of accuracy. This is safe, fast, and accurate, and leads to better outcomes. Here's an image of me using a similar navigation robotic system to place screws in the bones in a similar fashion. All of these things accomplish the same goal. You use a navigation system like you see on the right. You do a CT, have a CT scan, and you're able to know where in space the screw is going. Is it going in this where you want it? Yes, it is. And if used properly and with practice, this has significantly improved patient safety and outcomes. And it turns a challenging part of the operation into a straightforward, simple part of the operation. And any simple and straightforward operations are safer operations. The final concept that we've noticed in spine surgery, the final innovation we've noticed, is restoration of spinal alignment. The head is supposed to sit on top of the pelvis, of the hips. That's the way we're supposed to be designed. And as people age, people tend to lean forward. When people develop spinal disorders, especially of the low back, people tend to lean forward. And what we found over time is that the location of the skull over the pelvis predicts patient outcomes. So the goal of this is when you preserve or restore normal alignment of the spine, people get better outcomes. So on the bottom here, you can see that normal alignment of the spine looks something like this. When people have a flat back or abnormal back, it leans forward and it leads to a lot of back pain. Abnormal alignment of the spine leads to back pain and neurological symptoms. So the general idea is we try to restore or address spinal alignment problems and improve their outcome. So spine surgery is not what it used to be. It requires very specific approach. So the modern treatment requires 4 very specific approaches. Patient-centric approach, where we focus in on the patient, we focus in on you. A team approach, where you have many team members, clinicians, different nurses, different assistants, all kinds of people who work in the clinics and in the hospital to work as a team to take care of you. The third idea is evidence-based medicine, where we use the evidence provided to us in the data to drive what we do and what we offer. And then finally, keeping up to date with interventions. The durable innovations that we've talked about today and that will continue to show up over the next decade are motion-preserving surgery. Motion-preserving surgery tends to keep people moving, keep the spine that's supposed to be a mobile organ moving. It doesn't fuse the bones together. That's the whole point. The second general concept is minimally invasive surgery, where we use smaller incisions and smaller approaches to accomplish big goals. Building a ship through a bottle can lead to improved patient outcomes, faster recovery, and reduce opioid usage. But it's not always for everybody, but it's something that all surgeons think about for every patient they evaluate. The third general concept is image-guided surgery, where we use navigation systems and very high-resolution CT scans to help us accomplish complex goals in the safest way possible. And finally, surgeons always think about the restoration or preservation of spinal alignment to treat their acute problem and to prevent future problems in the spine. I'd like to thank my clinicians in my office and all my team members in my office who are invaluable help in making these presentations and also helping take care of patients every day here in the Northland. Take any questions here.
Well, that's fascinating to me, and I think it's really a great presentation. I will say from a professional standpoint, we provide as advanced spinal surgery here at North Kansas City Hospital as really any place in the region. So with that, we do have some questions from our audience. First question is, how does my metabolic function factor into my recovery? Age, thyroid conditions, those kinds of things.
So that's a great question. Metabolic factors and general medical issues definitely impact your recovery after spinal surgery and its spinal conditions in general. So for example, after spine surgery, good nutrition is important. Staying having good nutrition, eating well, those things are very important for recovery after spinal surgery. Avoiding nicotine is critical, whether you have surgery or not, for all spinal conditions. Making sure your bones are healthy is very important. So patients often suffer with osteoporosis or osteopenia, especially as they age. This is a weakening of the bones, especially common in women as they age. And screening yourselves for that, treating it when it's a problem, really helps with bone health and spine health in general, and other medical problems in general. The healthier you are, your body is, the faster and better you're going to recover from surgery. The more active you are, the better you're going to recover from surgery.
So a follow-on question for my own benefit is, if someone's diagnosed with osteoporosis, do you ever ask them to treat the osteoporosis before you consider the spine surgery?
I definitely do in many circumstances. So if somebody has osteoporosis and they are ultimately going to require some treatment that requires an implant, like a screw or a cage, especially in the low back, I like to have their osteoporosis treated as best as possible to try to improve the outcomes. And the reason is because if I'm having to place an implant like a screw in somebody's spine, if the bones are soft, those implants are more likely to fail in the long run than if the bones are treated and hard. So often I'll refer patients back to their primary care physician or an endocrinologist to have their osteoporosis treated or addressed prior to surgery. Sometimes that's not always possible. And we do have technologies and ways of trying to get around that. We sometimes can augment screws with cement in certain circumstances, like with cancer and things like that. That's on label, which is basically FDA approved. But in certain circumstances, we really want to use multiple tools to try to address some of these problems.
There's a question from the audience. I'm scheduled for a laminectomy and facetectomy later this month. Is a fusion an automatic part of the surgery?
The answer is no. So one way of thinking about spine, there's one simple way of thinking about spine surgery. There's one surgery where you remove bone and ligament and or disc material to take the pressure off the nerves. That's one type of spine surgery. The other type of spine surgery is you remove bone and ligament and disc or whatever you need to take the pressure off the nerves, and then you have to stabilize it in some way. Not everyone needs a stabilization. I would say the majority of people actually don't need a stabilization. Most people just need to have some more space. So whether it be creating a small window of bone or removing some disc material, not everyone needs a spinal fusion. And as a neurosurgeon who does a lot of spine surgery, I always ask myself that question: do I have to do a fusion or not? Because my goal are to avoid a fusion if I can avoid it, and to try to do things minimally invasive if it's reasonable or safe. If those two things are an option, I try to do them. And so avoiding a fusion is always a goal for many doctors. And so in summary, you don't need a fusion always. You only need a fusion if there is some level of instability before surgery, or you're going to have to create instability for one reason or another.
Great answer. Here's another question. I understand neuromonitoring technology can be used in surgery to help guide you. Could you describe what neuromonitoring entails and what that means for a patient?
So neuromonitoring is a technique that was developed about 20 years ago, and it is essentially an idea where a technologist would stimulate the nerves at different parts in their circuit and give the surgeon information about how well the nerves are functioning during surgery. So for example, the nerves can be stimulated at the scalp, and then the nerve impulses will go down to the legs, and then they record from the muscles in the legs to watch the nerves functioning. They can also watch the sensation function of the nerves as well. This provides a surgeon with information about how well the nerves are working during surgery. In certain circumstances, it may be irrelevant and not necessary for some surgeons in many surgeries. So for example, for laminectomies or microdiscectomies, I personally do not use them because it does not predict outcomes outcomes. It's not shown to improve patient outcomes. But for certain operations, it definitely does improve outcomes because it provides the surgeon with feedback about things that could change during surgery. So for example, if a surgeon is doing a complex deformity surgery and they have somebody monitoring their nerve function, if the surgeon is trying to correct a deformity and the nerve function declines or changes significantly after they correct the deformity, the surgeon knows that, let me undo that and see if it returns it, because it gives them some feedback during surgery about what to do. So it generally can improve patient outcomes in certain circumstances. That being said, I must say that it is not foolproof, and so it has to be, the information has to be used in with all the other information. So it can't be used in isolation. It has to be combined with all the other information, and it does require some clinical judgment to interpret that information.
There's a lot of information in the press nowadays about opioid addiction. So the question from the audience is, given what can happen with patients overly relying on opioids for postoperative pain, do you need to describe opioids? Are there steps that you take to limit or lessen the use of opioids postoperatively?
Mm-hmm. We definitely work as hard as we can to minimize opioid use during and after surgery. Some of the challenges we have are that a lot of patients come to us already on high doses of opioids. That's its own challenge. But with regards to surgery, there are several treatments as far as medications for pain control. There are anti-inflammatory medications that are prescribed. The over-the-counter ones that you all know about probably are Aleve and ibuprofen, but there are prescription versions of those as well. Anti-inflammatories are very helpful. For example, we provide those in our ERAS programs to help reduce pain. Simple things like Tylenol. There are nerve medicines. Nerve medicines help with nerve pain. Those are very specifically provided during and after surgery and before surgery. There are muscle spasm medications. All those medications that I just talked about are not habit forming, so we really rely on those heavily. Patients will need opioid medications often after some surgeries. That is just necessary, and it is expected. And there is a concern and fear about opioid use in general, but they are an important part of treating post-surgical pain acutely. And so we do prescribe them for a short period of time after surgery. And we let patients know that you shouldn't be shy about treating your pain. You need to treat your pain. But we do need to understand that this is a short-term thing. This is something that's going to be used for a short term after surgery, depending on the extent of the surgery, and something that should be weaned off as quickly as possible as you rely on the non-habit forming medicines.
Here's a common one from the audience. What's your opinion on inversion tables? Are they useful tools for treating or at least giving temporary relief for pain from a pinched nerve due to a misaligned lumbar vertebrae?
Inversion tables help a lot of patients. And so the concept of inversion tables is that the spine lines up with one another. It's a bunch of bricks stacked up on one another, and nerves leave at every level. As people age, those bricks get closer and closer together because the cushioning disc between them gets thinner and thinner. The idea between inversion tables is while you're laying down on them, it spreads the discs out, it stretches them out, and then while you're on that inversion table for that period of time, the nerves are not being pinched as much. And so that can be just all it takes, just that 20 minutes or 30 minutes on the inversion table to calm the nerve down and kind of slow down this cycle of inflammation in the nerve root. So they do help some patients. You can't fall off of them. That's critical. But so long as you don't fall off of them, they do help some patients. There is the same concept for the neck as well. If somebody has pinched nerve in the neck, there's something called cervical traction and a similar device that people use, and that works as well. I would say it falls in the domain of the physical therapy style of treatment, but it does work for some people, so long as you don't fall off of it.
That's great. I actually had a patient in my career who was treating his low back pain with an inversion table, and he fell off and ended up having problems in another part of his spine. So here's the last question. Just in general, what's on the horizon in spinal robotic surgery?
So in its current state, spinal robotic surgery is essentially a very fancy navigation system. It's a navigation system where you can place, the robot tells your arm where to put the screw. It's not exorbitantly different from the other navigation systems where you just go where the screw needs to be based on the screen. The future of robotics involves the next step, involves basically combining neuromonitoring information with the navigation system so that the tip of the instrument, not only do you know where it is in space relative to the MRI or CT scan, but the tip of the instrument will have feedback from a physiological standpoint. So it will, if it gets too close to the nerves, the robotic system, the tip of the instrument will tell you you're close to the nerves based on the monitoring. I imagine that's the future of robotic spine surgery, where it combines many different technologies and abilities, and makes it somewhat safer in many ways. And I think it's particularly helpful for minimally invasive surgery, where again, you're trying to accomplish a complicated task through a tiny little incision where visualization or seeing is a challenge.
A great answer. I really enjoyed this presentation. I thought it was fascinating. And to the audience, I want to thank you for joining us today. We hope that Dr. Hawasli's presentation was informative and helpful to you. Please join us on Friday, February 11th for our next Lunch and Learn presentation, Peripheral Arterial Disease, It's Your Arteries Talking, with Meritus Health cardiologist Justin Maxfield. Thank you very much for joining us today, and everyone have a good afternoon.